Bismillah ar-Rahman ar-Rahim. My name is Abdelghani Al-Shami, Professor of Surgery in Shams University. This lecture is about exocrine pancreatic tumors and cholangiocarcinoma. About 95% of pancreatic tumors develop in the exocrine pancreas. Pancreatic tumors are divided into exocrine tumors and endocrine tumors. This is the WHO classification of exocrine pancreatic tumors. The exocrine pancreatic tumors include the epithelial tumors, non-epithelial tumors, and secondary tumors. The epithelial tumors may be benign, like serous adenoma, mucinous adenoma, intraductal papillary mucinous neoplasm, and the borderline tumors include mucinous cystic neoplasm and the intraductal papillary mucinous neoplasm, and there is the solid pseudopapillary tumor. The malignant tumor includes ductal adenocarcinoma, serous adenocarcinoma, mucinous adenocarcinoma, intraductal papillary mucinous carcinoma, and the Acinar cell carcinoma. There is the pancreatoblastoma and the solid pseudopapillary carcinoma. The exocrine pancreatic tumors include ductal adenocarcinoma, the most common tumor. Other variants of ductal adenocarcinoma include adenosquamous carcinoma, undifferentiated carcinoma, colloid carcinoma, segment ring carcinoma, undifferentiated carcinoma with osteoblast-like giant cells, hepatoid carcinoma, Acinar cell carcinoma, serous cystic neoplasm, mucinous cystic neoplasm, intraductal papillary mucinous neoplasm, solid pseudopapillary tumor, and pancreatoblastoma. The ductal adenocarcinoma is the most common pancreatic neoplasm. It can grow large enough to invade nerves, which can cause back pain. It frequently spreads to the liver and the lymph nodes. Adenosquamous carcinoma is exceedingly rare. It accounts less than 1% of pancreatic cancer. It shows a squamous differentiation. This variant is important to recognize because it is associated with poor prognosis. Colloid carcinoma, microscopically, there are small nests of cancer cells floating in a pool of extracellular mucin. Many colloid carcinomas arise in association with intraductal papillary mucinous neoplasm. Hepatoid carcinoma. Hepatoid carcinomas are exceedingly rare. Microscopically, the cells look like cells of hepatocellular carcinoma. Acinar cell carcinoma, it accounts for 1 to 2% of exocrine pancreatic neoplasm. Metastases commonly occur to the regional lymph nodes, the liver, and other organs. Macroscopically, acinar cell carcinoma is circumscribed and may be multinodular. The individual nodules are soft and vary from yellow to brown. Areas of necrosis and cystic degeneration may be present. Microscopically, the cells of the acinar cell carcinoma has a characteristic granular appearance. The most common tumor is the pancreatic ductal adenocarcinoma. We will talk about it now. Ductal adenocarcinoma, its development is related to cigarette smoking. 80% occurs in the head of the pancreas. Macroscopically, ductal adenocarcinoma is firm and poorly defined mass. The cut surface is yellow to white. Hemorrhage and necrosis are unclear. As we have said, about 80% of ductal adenocarcinoma occur in the head of the pancreas, and about 70% of ductal adenocarcinoma is associated with biliary obstruction, and there is the characteristic desmoplastic reaction. Local invasion is common. Distal spread to the liver and peritoneum and lung also may occur. The pancreatic intraepithelial neoplasia are small microscopic precancerous lesions in the pancreas. They are called PanlNs. They are too small to be detected using currently available imaging technologies. If left untreated, some PanlNs will progress to be invasive ductal adenocarcinoma. So PanlN is the precursor of ductal adenocarcinoma. Pancreatic intraepithelial neoplasia has been considered as the precursor of ductal adenocarcinoma. Here we can see the PanlN1 and PanlN1B here, change from PanlN1A to PanlN1B to PanlN2 and PanlN3. The degree of dysplasia is increasing from PanlN1A to PanlN3, and this is considered as carcinoma in situ. The pathology of ductal adenocarcinoma and the sequence of change from normal cells to PanlN1 and PanlN2 and PanlN3, and here we can see normal cells, PanlN1A, PanlN1B, PanlN2 and PanlN3, and this will lead to ductal adenocarcinoma. If the tumor is cystic, also there is dysplasia in the what's called the intraductal papillary mucinous neoplasm and the mucinous cystic neoplasm, and this will lead to also cystic carcinoma. And here we can see the change from normal cells, here the normal cells, here cells with PanlN1A, here cells with PanlN1B, here the degree of dysplasia is increasing, here PanlN2 and here PanlN3. There is also genetic mutation. Here we can see KRAS mutation, and here we can see CDNA2A mutation, and also in PanlN3 there is TP53 mutation and SMAD mutation and BRCA2 mutation. Here is considered as a carcinoma. The risk factors for ductal adenocarcinoma include the family history of pancreatic cancer, smoking, alcohol, obesity, diabetes mellitus, chronic pancreatitis, and familial cancer. The symptoms of pancreatic cancer include asthenia, weight loss, anorexia, upper abdominal pain radiating to the back, but this will occur in advanced cases, jaundice if the tumor is in the head of the pancreas. Also, this will lead to bile duct obstruction, and the patient will develop dark urine and a clay stool with steatorrhea. Back pain is present in advanced cases, and thrombophlebitis is rare and is present about 3% of cases. The signs of pancreatic cancer include jaundice, palpable distended gallbladder, which is called Courvoisier sign. In advanced cases, the patient may develop epigastric mass, ascites, and cancer cachexia. This flow chart shows the diagnostic workup of pancreatic cancer after complete physical examination and laboratory investigation. For diagnosis and the staging of pancreatic cancer, we have to do a pancreatic protocol CT or MRI. Endoscopic ultrasound may be used in some cases. Also, CT guided biopsies may be done in some cases. ERCP is done to relieve jaundice for cases with marked jaundice. This slide shows the imaging modalities for diagnosis of pancreatic carcinoma. Ultrasonography is not sensitive. Ultrasonography is not sensitive for diagnosis of pancreatic carcinoma. CT and MRI are valuable for staging and diagnosis of pancreatic carcinoma. But we have to use what's called pancreatic protocol CT or MRI for proper staging and diagnosis of pancreatic carcinoma. US is valuable for diagnosis and staging of pancreatic cancer, and also we can take a biopsy guided by US fine needle aspiration biopsy. The PET-CT or positron emission tomography, computed tomography, is valuable to know the activity of the tumor and if there is mets, ERCP is used for therapeutic purposes to relieve jaundice with insertion of stent. CA199 is a tumor marker that is used for in pancreatic carcinoma. It is a glycolipid tumor marker. It is easily to be done, but it correlates with the advanced stages of tumor, and in early cases it is not sensitive, and so it is used only for prognosis and to monitor disease progression. This table shows the TNM staging of and prognosis of pancreatic cancer. In stage 1A, the tumor is less than 2 cm and confined to the pancreas only. In stage 1B, the tumor is 2 cm also, but confined to the pancreas. And in stage 2A, the tumor extends beyond the pancreas, but with no encasement of the vessels. In stage 3, the tumor involves the celiac axis or the superior mesenteric artery, and there may be lymph node mets, and the tumor is T4. And stage 4, there is distant metastasis. Pancreatic cancer staging correlates with the 5-year survival and median survival, and it is known that pancreatic cancer is of bad prognosis. Pancreatic cancer resectability. Pancreatic cancer resectability should be determined before embarking on pancreatic cancer surgery to determine whether the tumor is resectable or locally advanced or borderline. In resectable tumor, there is no extension to the celiac artery or the common hepatic artery or the superior mesenteric artery with patent superior mesenteric vein portal vein confluence. In locally advanced disease, there is encasement of the superior mesenteric artery or the celiac artery by more than 180 degree according to the site of the tumor. In borderline tumor, there is arterial abutment or encasement by nearly 180 or 180 degree for the superior mesenteric artery if the tumor in the head of the pancreas, or the celiac artery if the tumor in the body of the pancreas. This CT image shows resectable pancreatic tumor in the head of the pancreas. As we can see here, T here is the tumor, and this is the superior mesenteric artery. There is a clear fat plane between the tumor and the superior mesenteric artery, and here the tumor is considered as a resectable tumor. This CT image shows borderline resectable tumor. In this image, we can see this is the tumor. This is the tumor. A stent has been placed in the CBD here, as you can see it. Here there is the superior mesenteric artery, and this is the superior mesenteric vein. There is encasement of the superior mesenteric artery by about 180 degree here. So this tumor is considered as a borderline resectable tumor. In this CT image, we can see a locally advanced tumor. There is encasement of the superior mesenteric artery by more than 180 degree, as you can see here. This is the superior mesenteric artery. This is the superior mesenteric vein. This is the tumor. There is encasement of the superior mesenteric artery by more than 180 degree, and so it is considered as a locally advanced tumor. The general principles of treatment of pancreatic cancer. Pancreatic cancer treatment is a multidisciplinary treatment. The management of resectable disease is mainly by surgical resection of the tumor, whether by Whipple procedure for tumor in the head of the pancreas or distal pancreatectomy for tumors in the body and tail of the pancreas. This is followed by adjuvant therapy. The role of neoadjuvant therapy for resectable disease is controversial. For management of borderline tumors and locally advanced disease, the guidelines recommend chemoradiotherapy to downstage the tumor and to assess the patient to see if the tumor is resectable or not. The management of metastatic disease is mainly palliative. Surgery for pancreatic cancer. Surgery for pancreatic cancer will depend on whether the tumor is resectable or not resectable. If the tumor is resectable, pancreatic duodenectomy is used for tumors in the head of the pancreas. This is called the Whipple procedure. Distal pancreatectomy is done for tumors in the body and tail of the pancreas. Rarely, subtotal distal pancreatectomy or total pancreatectomy is done for tumors in the pancreas. The team of surgery should has ample experience in pancreatopbiliary surgery, and there is a rule for laparoscopy for diagnosis and staging of pancreatic cancer, and also it is used for selected cases of distal pancreatectomy and in very, very selected cases of Whipple procedure, but it is not standard for Whipple procedure. The standard procedure for Whipple is still open surgery. The post-operative care is very, very important for patients with pancreatobiliary surgery, particularly for cases of pancreatic duodenectomy and distal pancreatectomy, as the morbidity is still high, but the mortality has decreased significantly due to the post-operative care, and the mortality is less than 5%. The surgical procedures, here we can see the surgical procedure, whether pancreatic duodenectomy or distal pancreatectomy. Here we can see pancreatic duodenectomy, the parts which are removed. Here it includes the duodenum, the lower end of the bile duct, here the gallbladder, and here the duodenum has been removed here, and sometimes we may need to remove part of the stomach, the lower part of the stomach, and here the first part of the jejunum is removed here, and the head and till the neck of the pancreas here. So this part is removed, and reconstruction is done by pancreaticojejunostomy and duodenojejunostomy here, and hepaticojejunostomy. Yeah. Sometimes if the duodenum is removed, gastrojejunostomy is to be done. Here in distal pancreatectomy, here distal pancreatectomy, we need to remove the distal part of the pancreas, the body and the distal part of the pancreas, and together with the spleen, because it is a malignant an operation for malignant tumor, so we have to remove the lymph nodes here in this area, and distal pancreatectomy with the splenectomy is the procedure of choice for tumors in the body or the tail of the pancreas. Here we have to secure the pancreatic duct. Intraoperative assessment of resectability. This is an illustration to show the intraoperative assessment of resectability during surgery. Here we can see the surgeon has mobilized the duodenum, and the fingers are behind the head and neck of the pancreas, and behind the spuromesenteric vessels and spuromesenteric vessels here. This is the spuromesenteric artery, and this is the spuromesenteric vein, and this is the tumor in the head of the pancreas. These are the fingers of the surgeon behind the vessels and behind the neck and head of the pancreas for assessment of intraoperative resectability. This step is very, very important before embarking on resection of any part during surgery for pancreatic cancer in the head of the pancreas, and before doing a Whipple procedure. This picture shows Whipple procedure. Resection has been completed here. as seen. This is the superomesenteric vein. This is the superomesenteric vein. This is the superomesenteric vein, splenic vein confluence to form the portal vein. Here. And resection has been completed. Palliative therapy for pancreatic cancer. For advanced cases or unresectable cases, palliation of pain may be needed through celiac plexus neurolysis, whether CT-guided or EUS-guided celiac plexus neurolysis to palliate. Palliation for biliary obstruction may be needed also for advanced cases of pancreatic cancer with ERCP stenting. Here we can see ERCP. Here ERCP, during ERCP there is lung structure here, lower CBD structure. This is suggestive of pancreatic head cancer here. So stenting was done using plastic stent or metallic stenting. Here we can see the stent through the papilla, and this is the endoscopic view. This is the fluoroscopic view. This is the scope, and this is the bile duct. This is the long structure in the lower end of the bile duct, and palliation of biliary obstruction is being done by using ERCP with the stenting. Palliation of gastric outlet obstruction may be done using endoscopic stenting or laparoscopic gastrojejunostomy or open gastrojejunostomy. Here we can see endoscopic stenting by using the endoscope to insert stent in the duodenum for palliative treatment of gastric outlet obstruction. Key messages for treatment of pancreatic cancer. Resectability of pancreatic cancer is best determined by pancreatic protocol, CT or MRI. Resectable tumors are treated by upfront surgery, followed by adjuvant therapy. Borderline tumors are best treated with upfront chemotherapy or chemoradiation, followed by surgery according to the guidelines. Locally advanced tumors are treated by chemoradiation, endoscopic stenting if necessary, and the patient is reassessed for surgery later on. Metastatic disease is treated by palliative chemotherapy. The treatment of jaundice and gastric outlet obstruction is done when needed. Pancreatic cystic tumors. Pancreatic cystic neoplasms may be benign tumors or malignant or potentially malignant tumors. The benign tumors include serous cystic neoplasm, cystic teratoma, lymphoepithelial cyst, epidermoid cyst. The malignant or potentially malignant tumors include mucinous cystic neoplasm, intraductal papillary mucinous neoplasm, solid pseudopapillary tumor. Serous cystic neoplasm. It is more common in elderly women. The patient may present with a vague abdominal pain, or the patient may be asymptomatic. The tumor is much less common than the mucinous tumor. The tumor has many small cysts. Usually, serous cystic neoplasm is benign, and it's called serous cystadenoma. The treatment will depend on the site of the tumor and the symptoms, and if the patient is candidate for surgery, surgical resection is the treatment of choice. Surveillance may be needed for high-risk patients. This is a specimen of serous cystic neoplasm after resection. Here we can see the tumor, and there are many small cysts, serous cysts in the tumor itself. This is serous cystic neoplasm, and it is usually benign tumor. Mucinous cystic neoplasm. It is a mucinous tumor, macrocystic tumor. It is pre-malignant or malignant tumor. The great majority occur in women at younger age groups in the 4th or 5th decade. The tumor is large, about 6 to 10 centimeters in diameter. It may occur in the tail or in the body of the pancreas. The treatment is surgery according to the site of the tumor. If the tumor is in the body or tail of the pancreas, it is treated with distal pancreatectomy. Intraductal papillary mucinous neoplasm, it is more common in males than in females. In the 7th decade, the tumor is a multicystic mass from 1 to 2 centimeter cysts. There is bulging papilla during ERCP, which is characteristic, and there is mucin extruding from the papilla during ERCP. There is abnormal mucin producing cells that line the pancreatic duct. The adenocarcinoma sequence is well known here, and the invasive carcinoma has been reported in 35 to 50% of cases, but the tumor is less aggressive than the solid adenocarcinoma. The treatment of intraductal papillary mucinous neoplasm is according to the site of the tumor and according to the type of the tumor, whether main duct intraductal papillary mucinous neoplasm or branch duct intraductal papillary mucinous neoplasm. And the best treatment is surgical resection with frozen section at margins during surgery. Solid pseudopapillary neoplasm, it occurs in young females. It is well circumscribed tumor, and it's often large. There is a variable cystic and necrotic component. The tumor is of low-grade malignancy, and the best treatment is complete surgical resection. Solid pseudopapillary neoplasm. In this CT image, we can see a large tumor in the body and tail of the pancreas here, with the cystic and solid components. Here, the distal pancreatectomy with the splenectomy specimen here. Here, the tumor is large, and this is the spleen. Cholangiocarcinoma. Cholangiocarcinoma is a malignant epithelial tumor of the biliary duct system. 90% of cholangiocarcinomas are extrahepatic. The remaining 10% are intrahepatic cholangiocarcinomas. The tumor tends to infiltrate locally and metastasize. It occurs commonly in males and commonly at the 60s or 70s. The highest incidence is in Japan and Native Americans, and there is increase in the cholangiocarcinoma incidence threefold in the last 30 years in USA. The etiologic factors for cholangiocarcinoma include ulcerative colitis, sclerosing cholangitis, choledochal cyst, hepatolithiasis, and liver flukes, papillomatosis of the bile ducts, and other factors. Cholangiocarcinoma may be papillary, nodular, or sclerosing type. The best prognosis is with papillary distal tumors. The distribution of cholangiocarcinoma, as we have said before, 90% of cholangiocarcinoma occur in the extrahepatic distribution. In the right or left duct, about 10%, at the bifurcation 20%, the proximal CBD 30%, and the distal CBD 30%. Hilar cholangiocarcinoma, this is the Bismuth classification of hilar cholangiocarcinoma. Here we can see in type 1 Bismuth classification of hilar cholangiocarcinoma. The tumor is below the confluence of the right and left duct. Here the tumor has reached to the confluence of the right and left duct. Here in type 3A, the tumor has extended to the right duct here, and in type 3B, the tumor has extended to the left duct, and in type 4, the tumor extended to the right and left duct. In this slide, we can see a hilar cholangiocarcinoma extending to the confluence and above the confluence, and extending also to the upper part of the CBD and infiltrating also the cystic duct. It is a stenosing infiltrating lesion. The diagnosis and workup of cholangiocarcinoma, the patient usually will present with jaundice, weight loss, anorexia, abdominal pain or fever, ultrasonography, CT, MRI, MRCP, and ERCP may be needed accordingly. Also, some cases will need PTC if there is a failure of ERCP. CA19-9 may be elevated. This is MRCP for case of Hilar cholangiocarcinoma. We can see here the site of the tumor at the here. The tumor has infiltrated the upper part of the common hepatic duct and the confluence of the left and right duct. The left and right duct here can be seen clearly dilated here. This is the left duct has been separated from the right duct, and this is the site of the tumor. This is called Klatskin tumor. This is a fluoroscopic image of ERCP during ERCP for a case of cholangiocarcinoma. Here, this is the scope here. This is a fluoroscopic image here. This is the scope. This is the bile duct, the dilated bile duct. This is the dilated bile duct, and this is the dilated intrahepatic biliary radicals. And this is the lower part of the CBD. Here, there is structure, long structure here in the lower part of the CBD. This patient is in need for ERCP with stenting because the patient is jaundiced. The surgical therapy for extrahepatic cholangiocarcinoma. For proximal tumors or Klatskin tumors, resection is the best treatment. Right or left hepatectomy may be needed accordingly. Reconstruction by Roux-en-Y Hepaticojejunostomy is needed at the end of resection of the tumor for reconstruction. For mid-CBD tumor, the tumor is excised back to the negative margins, and Roux-en-Y hepaticojejunostomy is needed. For distal tumor, a Whipple procedure is necessary for cholangiocarcinoma. This is Roux-en-Y hepaticojejunostomy. Roux is a Swiss surgeon and who described the technique of Roux-en-Y hepaticojejunostomy. This is the Roux loop. This is the Roux loop. It is similar to Y. This is Y shaped here. The continuity of the intestine is here. This is the Roux loop for anastomosis to the bile duct here, to the proximal part of the bile duct here, here for biliary drainage here, and this is the jejunum end to side anastomosis here to form the Roux-en-Y configuration of the Roux-en-Y hepaticojejunostomy. For unresectable extrahepatic cholangiocarcinoma, the treatment includes a stenting with ERCP or PTC, percutaneous transhepatic cholangiography. Also, chemoradiotherapy is needed, and chemotherapy is 5-fluorouracil-based combination or gemcitabine or according to a clinical trial. Intrahepatic cholangiocarcinoma, as we have said before, it accounts for 10% of cholangiocarcinomas. It is a locally aggressive tumor. 65% of cases present with satellite nodules and perineural invasion. On CT, there is a suspicious mass. Biopsy may be needed to exclude. The treatment of intrahepatic cholangiocarcinoma, the surgical treatment is the best treatment for intrahepatic cholangiocarcinoma, but the extent of surgical resection is determined by the location of the tumor, the hepatic function, and the underlying cirrhosis. Anatomic resection has the lowest recurrence rate. A non-anatomic resection increases the potential of surgical candidate, and ablative therapy is used for unresectable tumors. For residual disease, radiation therapy is needed, and 5-fluorouracil-based chemotherapy or gemcitabine also is used. Re-imaging is needed by CT or MRI every 6 months for 2 years. The prognosis of cholangiocarcinoma. The best results are with distal cholangiocarcinomas when completely excised. Incomplete resection plus radiation gives a median survival of about 30 months. Stenting plus chemoradiotherapy gives a median survival of 17 to 27 months. Those stented alone live only a few months. Cholangiocarcinoma key messages. Cholangiocarcinoma is a malignant epithelial tumor of the bile ducts. It's a rare tumor but has seen increase in incidence in the last decades. There are challenges in the diagnosis and management of cholangiocarcinoma. Surgical resection is the only potential curative treatment. The problem of recurrent disease after resection is seen in many cases. Management strategies need multidisciplinary management. The 5-year overall survival rate is about 20%. Thank you very much.